Good morning or good afternoon, depending on where you are. I'm Dr. Eric Sarriot in the HSIS team of GAVI, and we're going to talk for about 10 minutes now about improving equity in immunization programs. But very specifically, we're going to talk about this concept of zero dose, which is kind of a central feature now of GAVI 5.0. So this is a short series of definitions which you may refer to in the future. I won't read them for you. Equity is obviously the main challenge that we're facing in our GAVI 5.0 strategy. Not a new concern, but now it's being really focused on zero-dose children, which we define because we need one metric, one indicator for programmatic investment and for accountability principles. So we're referring to DTP1, zero dose. But of course, children can be zero dose for polio, for BCG, if they are not delivered in a facility, even for tetanus toxoid, if the mother was not vaccinated during pregnancy. And so we realize that equity has many dimensions. We tend to focus on DTP1, but not at the exclusion of fully immunizing children or at the exclusion of the breadth of protection against all antigens. But the last point is the organizing principle, equity. That's what we're focusing about. That's our goal. So the next couple of slides are going to talk to us a little about the context of equity and specifically zero dose. And this first slide makes some key points about poverty, gender, and even sometimes ethnicity as a determinant of zero dose. And nobody is going to be surprised that, again, poverty is a major factor in lack of access to services, all kinds of services, and zero-dose children being found predominantly in poor households. So not a surprise. Gender can also be tied to zero dose, and we still know that there's a strong correlation between women not receiving antenatal care and skilled birth attendance and zero dose. And obviously, depending on context, ethnicity can be a big issue. So we are speaking about exclusion, deprivations, and poverty again as major drivers. So for a more quantitative slicing of the same problem, we can look at the population of children that we target as GAVI or that governments receiving GAVI support target. And we see that 13.9 million of them are not getting fully vaccinated by the DTP3 definition. Of course, we know that DTP3 is not full immunization. You need also to consider MCV2 and the whole range of protection. But if we just stay with DTP3 as an indicator, we see that among those, there's almost 10 million who don't even get DTP1. And that's part of the biggest challenge we have. And we know that the reduction in these zero-dose children has plateaued over the last decade. So we know that if we keep business as usual, we may improve health systems and we may improve some indicators, but ultimately, A, we won't get to where we want to be, and B, we may be building health systems that leave a lot of children behind. So we don't want to do that. So this slide tries to provide some reasons why we should invest in reaching zero dose because of the global goals that the community has given itself, sustainable development, because of value for money, because of impact, because of our beliefs in primary healthcare, because of health security reasons. But fundamentally, as we stated in the previous slide, the issue is equity, which is an issue, which is a moral issue at the heart of it. And do we want health systems that build in their DNA that the least of these, the last children, the poor children, the excluded, the marginalized, will get health services, and we build a health system that does that? Or do we build a great health system for the few that leaves behind the poor? Obviously, we know what we want to do, but it takes decisions and orientations, and that's what the zero-dose strategy tries to do. So this is another way that statistics can help us describe the situation with zero dose. And basically, We can look at urban poor, remote communities, and nomadic groups, and finally populations in conflict settings, which are sadly increasing as major groups of populations which are zero dose. Actually, together, these represent about 50% of the zero dose that we globally target. And so it's important to note a couple of things. First, there's a lot of variations in context, even between regions in context. And then these three groups represent 50%, which is a lot, but they also only represent 50%, which tells you that there's going to be a lot of micro conditions, more complex conditions that are going to have to be identified in countries to really reach communities. And we'll talk more about this. But as I believe the audience of these trainings is social behavior change community, we obviously are going to have to think about the strategies to help reach these urban poors, these remote and nomadic communities, population in conflict settings, obviously a multi-sectoral issue. But now these communities that are spread out in less identifiable groups, in their communities, that is going to require different strategies and different costs to reach them and have an impact. And I think that's nothing extraordinary for people that have worked in social behavioral change, where segmentation of audience and target groups, to use that language, has always been on the forefront. But we start with three big groups that are easy to recognize, and then we move on and understand that in-country variation is going to be tremendous. So now for a quick segue onto what happened with COVID and the COVID vaccination efforts. Obviously, things have gotten harder. We know that. And families with less accessibility didn't gain anymore because there was COVID. So it's been a challenge. There's been opportunities in terms of demand, social behavior change, and getting more creative. And because we realized how vaccines resistance came from breaches of trust. So that's a direction of promises. But on the service delivery front, obviously, vaccinators cannot be delivering COVID vaccines to adults and routine immunization to children at the same time. So we need to redress that. And we need to continue working on demand, and that's an area where integration can happen if we start building integrated platforms that can last and move beyond project by project investments in community health, which have very negative effects in the long run. So the next two slides are just examples of typologies of situations you will face, and I will let you read them. The first one is about looking at places that have low coverage with big conflict areas, fragmentations, a large number of problems, usually requiring humanitarian interventions. And then we're going to focus on the next ones, which is kind of the opposite, but we'll see how both can exist in the same country. We'll take one example. Here we illustrate a context of high coverage, and then zero dose are in localized communities or pockets. So we're going to need a lot of triangulation to try to understand where are these pockets? Why is there so much high coverage and then some places where it doesn't happen? Is it urban areas? Is it migrants? Is it unregistered people? Is it ethnic minorities? And we're going to have to do more studies, the kind of formative studies that are useful for social behavior change, in addition to targeting health service intervention. And we need to understand the barriers. And going to need, and that's where I think the social behavior change colleagues are going to be familiar with this language. We're going to need tailored strategies, to understand. And how do you engage the communities? If it's neighbors in communities that have high coverage, but you have neighbors that are forgotten, what strategy are you going to need to get there? Are you going to need something like the care groups, like My Village, My Home, like participatory women's groups? What are you going to need? Community registers? What are you going to need? And what are you going to need as the interface between the demand, the community approach, and the service delivery? And if the coverage is high, the services are here. So is that a problem of certain groups not being well treated, received, or gaps in quality? You need to look at all the complexity of these questions. And gender is a big one, culture, etc. So you see that there are situations where you are going to have big clusters, which may be big challenges to address, with conflict, but not complex in the understanding of the problem. And then you're going to have areas where the zero dose may be many, but scattered throughout areas, so they're kind of invisible. And then the challenge there will be to have identification and reach kind of going hand in hand. And because kids are going to keep being born under these conditions. And just to end with an example, that's the situation we're in with our colleagues in Burkina Faso, with the excellent Ministry of Health teams and partners have been working at this, and we have a conflict situation where health services are being prevented from happening, health structures are being destroyed, sadly. So obviously, some kids are not going to get vaccination. We're going to have zero dose there, and then we're going to have few districts with high urban concentrations where, in spite of good coverage, we have high numbers because of urban density. But then overall, we have a large number of districts, majority of districts, which have very high coverage, so low percentage of zero dose children. And yet that represents half of the zero dose children in the country. So you see that there, the questions are going to start being trickier, and they're not going to be addressed in 2 or 3 months, but over time, as the health systems builds its quality, as the partnerships with on the ground organizations, civil society, as the partnership with research is going to improve so that we can address the challenge. So thank you for your attention. I hope you gleaned some key concepts and maybe interesting references to follow on in this presentation, and remains to thank you for your work and your service to the health of children, keeping the poor and the least of these, as some people say, at the center of our health system strengthening strategy and social behavior change. Thank you.